In our first session today, Tracy Danilishan-Laycock is a behavioral consultant in the Saskatoon Health Region for the 30 long-term care homes. She is a social worker by trade and is currently doing the PhD program in the College of Medicine. Her doctoral degree is in collaboration with Dr. Deborah Morgan, professor at the College of Medicine, the University of Saskatchewan. Tracy is one of the 3 master coaches in Central and Western Canada for the Gentle Persuasive Approaches program. She also works with the Seniors Mental Health Outreach Team and is managing responsive behaviors in residents with dementia. Welcome, Tracy.
Thank you, Jill. Well, I'd like to say good morning to everybody. This is a great opportunity for me to speak with people across the province. Most of the people in Saskatoon Health Region know me, but this is a chance for me to branch out. And so I was invited to speak about dementia and delirium. And so what we'll do this morning is do a 45 to 50-minute discussion on the different types of dementia. We'll do a 10-minute break, and then we will come back and I'll do my session on delirium as well. So what I would like to do today is just talk about the new diagnosing of dementia. I would like to talk about the different types of dementia that you will see and some of the behaviors that you will see as a result of them. And then I would like to talk about delirium and the different types of behaviors that you'll see with them as well. So as I'm going, if you have any questions or things that just aren't sitting right, feel free to ask them at the end of the question and answer period, and we can try and answer as best we can. So if you look on the PowerPoint presentation, one of the newest things that's come out in the last year is that in the DSM-5, it's called, that's the statistical manual that psychiatrists and psychologists use when they're diagnosing mental illnesses. And so once upon a time, we used to call dementia, but in this new book now, it is now being called the neurocognitive disorder. In saying that, healthcare providers are still calling it dementia. So I'm going to refer to it as dementia, even though in the DSM-5 it is called the neurocognitive disorder. Dementia really is not a disease of itself. It's an actual umbrella term that describes a set of symptoms. And so the best way that I can think about describing the types or how to relate dementia to the different types of dementia is looking at this analogy. So as children, we've all had soda pop, right? There's some things that are very in common with soda pop. They're sweet, they're carbonated, they are dark in color, they're high in sugar, we crave them and they get our kids all wound up. However, if you look deeper underneath the umbrella, there's different types of soda pop. So Pepsi, root beer, 7-Up, Sprite, Orange Crush. They all have the same, they have different flavors, they have different colors, some of them don't have as much sugar. So that's how you can kind of look at dementia as the soda pop and the different types of dementias as the different types of soda pop. So root beer is a little bit different than Pepsi, Pepsi is a little bit different than 7-Up. And so with each one of those, you've got some different characteristics. So when you're looking at dementia, it can be diagnosed as either major or mild. But what you will notice is that there will be impairment in memory, attention, language, learning, perception, and cognition. And it may not be at the same time, but it will be in different types, different areas over the progression of the disease. So the first thing that I want to touch on is the mild neurocognitive disorder. It's different than what you will actually see with healthy aging. These impairments that you will have are beyond what is normal for the aging as we go. It's not a normal part of aging is basically what I'm saying. So symptoms of mild neurocognitive disorder include, if you look at the PowerPoint presentation, you'll notice a significant decline in the cognitive functioning and performance of an individual. So that family member may notice that they're not remembering as well as they could. They're having difficulty performing tasks. They're having issues with language, and they're having issues with social skills. So they may not be as socially compliant or as socially acceptable as that they were at one point. In mild stages, you will see mood disturbances. So you will see an increase in anxiety because they know that there's something wrong, but they just can't maybe at that point put their finger on it. You may see some depression, some agitation, and some apathy. These are often the most noticeable signs that the family members will come up with. One other thing that you will see is sleep disturbances. So you'll either see insomnia, which is not being able to sleep, or hypersomnia, which is really excessive daytime sleepiness or excessive prolonged nighttime sleeping for hours on end, and it's happening for over 2 months or more. What I do see when I'm out in the community, I do tend to see in the earlier stages people that are also up at night and they're eloping, and so that becomes a safety risk too. And so some of those things that are, for those of us that are caring for loved ones out in the community, those are things that we need to consider about, is the nighttime, the wandering, the behaviors. And it's really very, very difficult on caregivers that are caring for somebody with dementia. So to diagnose the dementia, the mild form, there needs to be a couple of things that have to happen. So there needs to be evidence of moderate cognitive decline from a previous level of performance in one or more of the following areas. So they need to have a decline in complex attention. So that's their ability to pay attention to something, not just one or two things, but higher level things. They need to have impairment in executive functioning, and executive functioning is things like reasoning, judgment, understanding of consequences. They'll have impairment in learning and memory. So you may think that they can learn something new, but at that time, they're not struggling. They're really struggling to learn as best as they can. You'll see impairment in memory, language, whether it's not being able to find the words, or the words that they're saying aren't giving the meaning that they're actually trying to give. They'll have issues with perceptual motor, so that's moving and muscle movement, as well as social cognition. The two diagnostic criteria that you need to know is that the individual has noticed these significant changes, is one, and the other one is that there needs to be moderate impairment in cognitive performance, preferably by standardized testing. So those are the two things that they look at, is what is the family member saying, and what is the diagnostic criteria saying about how that person is doing. For it to be mild, they're basically saying that the cognitive deficits do not interfere with the independence in everyday activities. They're still able to function, but you're starting to notice some impairment in some of those areas. Okay, so when you move on to the major neurocognitive disorder, or the late stages of dementia, the diagnostic criteria is similar, but it's a little bit different. So when you're diagnosing somebody with major cognitive disorder, they need to have evidence of three things. So the first is evidence of significant cognitive decline from the previous level of performance in one or more of the following. So you'll need to see a decrease in attention, their executive functioning. So how are they reasoning? Are they understanding the consequences of what they're doing? Are they able to remember things? Are they taking their medications? Did they know that they just called you 10 minutes ago at home? How is their language? Are they able to put together a sentence, or is the sentence even making sense? How are they walking, and how are they out when you take them out in public? And this information that we gather is based on, again, concerns from the family member or somebody that knows them very, very well, or standardized tests that are done within the doctor's office or other testing centers. You'll also notice that these deficits will interfere in everyday activities. The cognitive deficits do not occur exclusively in context of a delirium, so these are things that are happening outside of a delirium, and what a delirium is we'll talk about at the end of the day. And the cognitive deficits are not better explained by another mental disorder. So going through all that big book, the DSM-5, and this is what we're coming down to. These are what the symptoms are related to, is to the dementia. So what happens when you have mild major neurocognitive disorders? Well, what you're going to see is you're going to see behavioral differences. You're going to see some type of behavior at some point in the disease progression. It may not happen right at the beginning, but it may happen at the end. And research shows that somewhere between 80 to 90% of people that have been diagnosed with a type of dementia will have some type of behavioral issue going on with them. And what those look like and how they present, we will talk about a little bit in the PowerPoint presentation a little bit later. Clinicians can also identify the severity of the major neurocognitive disorder from mild to severe. So if it's mild, they'll have difficulties with instrumental activities of daily living. So they may not be able to do their housework. They may not be able to balance a check. They may have moderate impairment, which is difficulties with basic activities of daily living. So they can no longer feed themselves. They're having a tough time toileting. They're not able to get their clothes on properly. Or they may be severe where they're fully dependent for lifting, transferring, feeding, all their day-to-day activities. And I typically see the people with moderate or severe living in long-term care homes in the health region. So there are several different types of neurocognitive disorders. I've only selected the first few to talk about because those are the ones that we typically see more in Saskatoon as well as in Saskatoon Health Region. So these can be specified as a result of dementia. So they're Alzheimer's disease, frontotemporal dementia, Lewy body disease, vascular dementia, mixed dementia. You can have dementia related to substance abuse and medication use, traumatic brain injury, Parkinson's disease, Huntington's disease, and others. But we are just going to focus on Alzheimer's disease, frontotemporal disease, Lewy body disease, and vascular and mixed dementia. So here's a brief video clip, a couple of minutes long, that just tells you basically the overview of dementia. I'd like to move now on to Alzheimer's disease. And what I typically hear when I'm out in the public or I'm out in the nursing homes, I'll hear, well, my mom doesn't have dementia, she has Alzheimer's disease. Two very different things. And actually it's not. As I mentioned earlier, dementia is an overarching set of symptoms that talks about the different types of diseases. So Alzheimer's disease is a dementia. It's a type of dementia. And so as we know, and there's many, many websites that you can go to, the Canadian Alzheimer's Society or the Saskatchewan Alzheimer's Society has a great link, so does the Canadian Alzheimer's Society. They have lots of stuff on their website as well. But it's the most common form of dementia in Canada. The impairment related to Alzheimer's disease is related to changes in the brain called plaques and tangles. And really what happens is that the brain shrinks. And right now, the impairment is most likely related to genetics and the environment. And there are different researchers out there that are looking at different things. There's no one true, aluminum in your underarm deodorant is causing dementia, or too much of something else is causing Alzheimer's disease. There's just very different camps out there, and there's actually not one sort of relating factor that we can put a finger on it right now. What we do know is that the progression of Alzheimer's disease is slow and irreversible. Typically, from the people that I've worked with over my 10 years in this job, is that it's between 8 to 15 years, plus or minus a couple of years on either end. What you'll see with Alzheimer's disease is you'll see a gradual and progressive over time. The primary sort of symptom that you're going to notice is a prominent memory loss. What you will also see is an impairment in language, judgment, mood, and behavior. So again, you may see some anxiety, you may see a little bit of aggression. You're probably going to see more of the repetitive calling out, the repetitive questions, because they're not exactly sure if they've eaten, if they've gone to the washroom, where has my husband gone? You'll see delusions present at moderate stages. And for those of you, a delusion is a belief in something. It's not a hallucination. It's a belief that there's something out there that's absolutely real to them. You will see a shrinkage in the hippocampus. So if you look at the two pictures on the slide, you'll see a healthy brain versus an unhealthy brain, and the brain on the left is the brain that's shrinking versus the healthy brain that's on the right. What you'll see, again, as I mentioned earlier, is your key indicator of Alzheimer's disease is the memory loss. So the individuals will experience forgetfulness that occurs much more frequently and persistently than associated with normal aging. So you may once or twice lose a book, or once or twice lose your keys, but if you're getting phone calls at work from your mother saying, well, when's the bus coming here? Or where's my purse? I can't find my purse. Over and over and over again, that's more than normal aging. Common complaints include, at this time, that they're having difficulty remembering appointments, so they may have to use a calendar. They have trouble remembering details of specific conversations or aspects of programs. Or they may tell you the same story over and over and over again because they can't remember that you've told you that already. In the initial phase of this illness, there are learning difficulties and delayed recall, so they're having a hard time keeping things in. So if you tell them something, they're not remembering it, and then they can't spit it out after when you've asked them about it. They have difficulty with specific words, naming objects, so a toothbrush may be a brush, a knife may be a spatula. They know the word that they want, but they just can't get it out. It's on the tip of their tongue, but they can't spit it out. They're having trouble in constructing fluent and informative sentence. As well, in addition, elements of executive function, which is sort of the upper lobe ability of reasoning, judgment, memory, thinking. They're having difficulty doing that. They'll have problems with problem solving, judgment, and calculations. So they may accuse people of stealing. They may have repetitive phone calls at work. I worked with a lady in the community who had written the same 8 checks to the same individual as a Christmas gift, not realizing that this person was taking financial advantage of her, not realizing that she had written the check 8 times and had depleted her bank account. So that shows you sort of that upper lobe ability or inability to not be able to manage the higher finances with Alzheimer's disease. So what will you see with Alzheimer's disease? Well, I mentioned a few of them, but you will also see memory loss that affects daily functioning. So again, where are my glasses? Where are my teeth? Where's my purse? Where are my keys? They'll have difficulty completing tasks. So you may say to your mom, if she's living with her, you know, could you just do these dishes for me? And you come back 10 minutes later and she's standing in front of the sink crying because she's not sure what she's supposed to do. They'll have issues with language or word finding, as I mentioned before. And the disorientation. This is what I typically see out in the community, is that people have been disoriented to time and place and date. They think they know where they are, and then all of a sudden they realize, I have no idea where they are, and then the family member gets a phone call from the police saying, your mom is here, she doesn't know where you are, could you please come and get her? And again, when they're not sleeping at night and they're disoriented to time and they're trying to get outside because they think maybe the cattle have to be fed or the dog has to be let in, then the next thing you know, they're outside and it's 40 below and they're trying to find the dog or the cat. So the disorientation is actually causing a safety issue. Again, problems with abstract thinking. They're going to misplace things. They'll have changes in mood and behavior. When I do go into homes, I do hear, or even when I talk with families in nursing homes, I hear, this isn't the mom that I knew. So they have the changes in the mood, the behavior. They may suddenly become very angry. They may become very, very negative. And it's very, very hard on the family to hear that because that's not what their mom was like before or their caregiver was like before. They may also become apathetic. And apathetic is something that is impaired in the brain, which is very different than depression. And so when you're apathetic, it means that you don't think to involve yourself in the outside world. You don't know that there's other things going on out there. If you knew, and if somebody said to you, hey, do you want to go to the show? Sure, let's go, and they'll go. But people that are apathetic really don't have the highest quality of life because they don't think to involve themselves in things. So in nursing homes, in people's caregiving homes, it's up to the staff or it's up to the family member to engage these people because they don't think to engage themselves, which is different than depression. And what Tammy will talk about a little bit later. So you need to know the difference between apathy and depression. It's really the inability to think to involve themselves in something. And then again, spatial awareness, not sure where they are out in space, and so you may have some falls as a result of that. So the next type of dementia that you see, and this is actually more rare than what I typically see out in long-term care, is what's called frontal temporal dementia. So we have 2 lobes in the brain. The one up here is your frontal lobe, and the one back over here is your temporal lobe. And these are the 2 lobes that are impaired with this particular type of dementia. It affects individuals earlier in life, typically in their 40s and their 50s, if you'll notice on the second point. And it has a stronger genetic component than Alzheimer's disease or vascular disease. And again, it is progressive in nature. It's not something that will stop. It is progressive. It's a typical younger age of people that have frontal temporal dementia. And if you look at the ratios of frontal temporal dementia to Alzheimer's disease, you'll see it's 4 to 1. So for every 4 people that have Alzheimer's disease, 1 person has frontal temporal disease. So with frontal temporal disease, it is often misdiagnosed as a mental health disorder. And there are actually 2 different types of frontal temporal disorder, and they are called frontotemporal behavioral variant, or FTD-BV, or primary progressive aphasia variant, or PPA, and I'll talk about each one of those. So basically what that's saying is that if you have frontal temporal dementia, potentially you'll have the behavioral variant or you'll have the speech variant. So symptoms of the frontal temporal dementia of the behavioral variant include early onset. So I have to say that in my 10 years of working in Saskatoon Health Region, I typically see males in their late 40s, early 50s that have had this disease. Not to say that women don't get it. I have seen women that have it as well, but typically the ones that I see are males primarily. You will see different changes in their personality. So it's very, very early in the disease. So people with frontal temporal dementia still have a job. Teachers, bankers, you know, they're going to work, but then they're doing different things that they weren't before. So they maybe were showing up late for meetings, or they were losing their temper, or they weren't able to follow through the things that they were supposed to be doing. And that's when their employer goes, this is different. Something's not right here. They become disinhibited. So I've worked with people that have had risky sex in parking lots, will have stripped naked out in public. I've had people that have had poor judgment in social interactions. So a family I worked with couldn't take her husband to church anymore, and that's sort of what they lived for, was a church community, because he would always be standing up and hugging everybody. So the communion line would be going through, and he'd be getting up and he would be hugging everybody and patting everybody on the back, even though he didn't know them. And she was very, very embarrassed for him. They'll have little to no understanding of the consequences. So they may, I worked with a lady that went through $100,000 in 6 months gambling, just not realizing that this is all the money I have and I'm living in my car and I don't know where else to go. Memory goes later in this disease. What typically happens is that because the people are so young that have frontal temporal dementia with the behavioral variant, people notice, and so they're sent to their doctor, they're sent for an MRI, they're sent for a CT scan, and they're sent to the psychiatric center because they're doing things that are, you know, present as schizophrenia or bipolar and things like that. And it's not until they actually do the in-depth testing that they find out that that person actually has frontal temporal dementia as opposed to a mental health disorder. So you will see some very, very risky behavior. You will see some definite lack of insight into what it is that they're doing. What I do see with the gentlemen in long-term care that have frontal temporal dementia is I do see the aggressive behavior, the sexual stuff, the swearing, and the aggression towards other staff or co-residents. So symptoms of frontal temporal disease with the progressive aphasia includes the language. It's affected in the earlier stages of the disease, but the behavior is also impacted as well. As the disease progresses, so will your behaviors. There's two forms of PPA. The first is called semantic dementia. So individuals are able to speak easily, but the words carry little meaning. So you can meet somebody and they can string a whole sentence together to them, but if you actually stop and you listen, the words aren't making sense. And you can't follow the sentence and you don't know exactly what that person is saying. Where in the other kind, progressive non-fluent aphasia, the individuals struggle to generate words easily and the speech sounds very choppy. So they're struggling and they're trying to get words out, but they're very, very few words. And then again, they're difficult to understand. So these are the people that you have to ask questions to. These are the people that you have to cue in order to get the meaning across. I find that when I work with people with frontal temporal dementia with the aphasic variation, that I use cue cards. So I'll just go up and I'll go, say if they're struggling to have a bath or staff are struggling to work with them to change their clothing. I'll go and make a clip art picture of a pair of shoes or a clip art picture of a bar of soap or a bathtub, and I'll show it to that resident and point, just so I can get my message across to them that this is what I want them to do or this is what I'm asking them to do. And oftentimes they're able to point at you too, to be able to tell you what they would like to do. It's just a matter of giving them that time to be able to do it. So a third type of dementia is called Lewy body dementia. And Lewy body is more rare as compared to Alzheimer's disease. Lewy body is actually caused by protein deposits called, lo and behold, Lewy bodies. Discovered by the person that found the Lewy bodies, that's who they're named after, in the nerve cells in the brain. Again, Lewy body can occur on its own or with Alzheimer's disease or Parkinson's disease. And Lewy body dementia accounts for 5 to 15% of the dementias in Canada. So symptoms of Lewy body include visual hallucinations. And so you need to know that visual hallucinations, when you have somebody with Lewy body that has that disease, it is absolutely real to them in that moment. We may not be able to see it, we may not be able to see it, hear it, taste it, but it's absolutely real to that person. And the more that we argue with that hallucination to tell them that it's not real, the more upset they get, and that's when these people become aggressive, especially in the later stages. So you will see visual hallucinations. They may see small children, they may have conversations with people in the room that aren't there. When you look at the beginning of the disease, there's earlier onset and short-term memory loss compared to Alzheimer's disease. There will be an impairment in attention. They'll have executive functioning, which again means the reasoning, the judgment, the understanding of the consequences. And visuospatial skills featured in Alzheimer's disease. In addition, you will see the Parkinsonian type features. You'll see some tremor, you'll see some balance issues, walking problems, and some stiffness later in the disease as it progresses. One thing that I do notice quite regularly is with the Lewy body, you'll see depression and anxiety. They don't often want to be left alone, or they're wondering where their people are, where's my family, where's my caregivers. You'll have the sleep disturbances, and you'll have falls. And so you have to remember with the hallucinations, they are very, very real. And in 2/3 of people that have Lewy body dementia will have the hallucinations. They fluctuate from hour to hour and day to day. They can see people, mostly children, and animals that appear real but make no noise. But if you ask that person, they can provide you rich and thick detail about what's happening to them in terms of color, touch, that kind of thing. These hallucinations often coexist with perceptual difficulties and misidentifications, and they typically occur daily. Again, depending on the hallucination, emotional response varies from indifference or even amusement. Sometimes they're laughing, sometimes they're crying. Sometimes they have intense fear. So delusions, as I mentioned earlier, are the belief that something is that there's a belief that's not real. It's real to them, but it's not real to us. It's often secondary to the hallucinations, but you'll see 65% of the people with Lewy body dementia having those types of delusions. With Parkinsonian features, up to 70% of people with Lewy body will have Parkinsonism. The tremor may be uncommon. You'll have instability, you'll have rigidity, is probably more common. Again, you'll see deficits in attention, executive function, as I mentioned earlier, and visuospatial. So they may not be able to understand where they are in space. They may trip over a chair. They may be cutting too close to the wall. They may not be able to transfer properly into a car. So really, as I mentioned earlier, to sum it up, the most prominent symptoms of Lewy body dementia include earlier visual hallucinations, often of children, early Parkinsonism, more rigidity than tremor, fluctuations in cognition, so again, from hour to hour and day to day. You might be able to have a very good conversation, and then you come in 2 hours later and they're having a hallucination. 50% will have neuroleptic sensitivity, so that's sensitivity to medications that will treat it. And some of them will have relative memory sparing earlier on, but lose it as it goes. And just one gentleman that I've worked with in a nursing home, he was a police officer. And he was in a nursing home where there was a cross with Jesus on the cross with blood spilling out of the hands. And when this person had Lewy body, every time he would have a hallucination, he would think that there was somebody that was murdered out in front of his door. And so he would get all wound up, very, very upset. And the staff would have to say to him, like, no, this isn't real, this isn't real. And the more they argued with him, the more upset he got. And he was a police officer, and he was trying to get to the front door, and he needed the keys, and he needed somebody to help him. He just, in that moment, had such terror and extreme want to be able to solve this problem that the staff had to work with him through the hallucination. Come back 2 hours later, everything is fine. So they will have good moments and they will have bad moments. It's like a dimmer switch with anyone with dementia. Some days are good and some days are not so good. I worked with a lady who hadn't spoken in 6 months, and I was watching them do a bath, and she all of a sudden turned up and looked at me and she said, "You sure are pretty." And the staff said to me, that's the first thing she said in 6 months. So again, it's about going with the moment, being with them in the moment, and helping them through the moments that they need the help So vascular disease is also very common that we see. I typically see when I go into long-term care probably 1 out of every 3 people that have vascular dementia. And vascular dementia is caused by a lack of blood flow or strokes to the brain, causing cells to die. It's the 2nd most common form of dementia in Canada, and it really affects depending on where the strokes are. So if you've got issues in your parietal lobe, you may have troubles with your speech. If you've had a stroke in your occipital lobe, you might have trouble with seeing. So it's really hard to compare one person to another person with vascular dementia because it really depends on where those strokes are happening. So the onset of vascular dementia may be rapid, but it may also be gradual, depending on the number and the intensity of the strokes. Looking at the research, risk factors are one of the biggest sort of symptoms that bring on vascular dementia. So people with high blood pressure, high cholesterol, people who smoke, people that are diabetic, people that drink, and people that have heart disease are all at risk of having vascular dementia. We will see that 8 to 66% of people with vascular dementia will have depression over their progression of the disease. So I mentioned earlier, vascular dementia is caused by problems with small or large blood vessels. You'll be able to see the imaging. If you look at a brain scan, you'll be able to tell that there's vascular impairment. And again, the risk factors include smoking, diabetes, heart issues. It can follow a stepwise progression with periods of stability. And again, if you have another stroke, you'll see a decrease in function. It's associated with non-cognitive features, so you'll see changes in depression, apathy, emotional lability. So those are the people that will be sitting there 1 minute having a great time, and then you're having a conversation with them and they're crying. And you don't know why you're crying, and they don't know why they're crying, and they can't put their finger on why they're crying. It's just the mood lability of the disease. They'll be disinhibited, so you may have them hollering, they may be swearing. Lots of people that I work with vascular dementia, these are the family members who say, "This is not my mom. I don't know what happened to my mom, but my mom never ever would have swore. My mom never ever would have taken her clothes off. My mom never ever ever would have negatively said anything about anybody here." With the disinhibition, with the swearing, you may also see taking clothes off. You may not see them changing their clothes. You may see them fighting during care because they don't want anybody to come near them. There may be aggression, and again, the aggression may be related to a lot of things. And we can talk a little bit about that later, but sometimes the aggression in the vascular dementia comes because they don't want you to do something to them. They don't want you to change them. They don't want you to bath them. They don't want you to do something, and they're actually doing it as a response to something not right in the environment. So they're saying, you know what? I don't know who you are. You're a stranger trying to take my clothes off. I'm going to protect myself, and that's where the aggression comes from. Typically, the aggression is as a result of defending themselves because they are confused. They may have short-term memory loss. They may be living in a nursing home. They don't know who you are from day to day, yet you're in their most private space trying to do some type of care. So again, more symptoms of vascular dementia include executive impairment. So again, what that means is that their higher reasoning and their ability isn't quite working. And so what I typically see in long-term care is somebody that has gotten a resident that has gotten upset at one resident because they ate their meal, and then that resident hit that person. And then the staff will get upset, and then I will hear from the staff member saying, "She knew what she did." And I'll say, "Well, how do you know that she knew what she did?" "Well, because she apologized later." I said, "Well, that doesn't necessarily mean that she knew what she did. What that means is in the moment, her executive impairment wasn't working. She was disinhibited. She was upset, she got angry, she reacted, not understanding the consequences of her behavior. What you're seeing is the fact that she remembered that she hit somebody. But what you need to remember in the moment is that she was frustrated, angry, whatever the feeling was behind it, and they lashed out, not being able to understand the consequences of their actions. They remembered that they did it, but in the moment they couldn't stop themselves. And so that's where, when I go into long-term care homes, I'll just say, you know what? Yeah, it wasn't the right thing to do, But in that moment, for that person, that area of their brain that would have stopped them from hitting wasn't working. I call it the filter. So if we all have the social awarenesses to not hit somebody because you don't like what they're doing. But when you have dementia with executive impairment, that part of your brain is gone. It's not working anymore. It's not going to come back. And so it stops you from doing things that you wouldn't normally have done before. And the best way that I could describe this for frontal temporal dementia, for frontal temporal impairment and vascular dementia, is think of yourself. Has anybody ever had a black thought in their life? In Saskatoon here, anyone ever thought anything bad about somebody? Yeah, there's a few heads nodding, and I'll say the exact same thing too. When you have that impairment, when your executive impairment isn't working, you actually may potentially act out on your black thought. And that's what's scary, is because you no longer have the ability to stop yourself from doing the things that you once were able to do. I'm not going to hit Tammy because I wanted her topic of discussion, because I know not to do that. But if we're two residents that live in long-term care and maybe she's taken my cup, I'm going to get mad. It's mine, and I'm going to hit her back. So one of the things to remember about, well, maybe I'll just talk about behaviors in just a little bit. So you will see with vascular dementia, you'll see some change in attention. So you may see them at one point being able to read a book, or prior to their dementia, they may have been able to sit and do a 5,000-piece puzzle or play bingo or something like that. As a disease progresses, they may not even be able to concentrate on reading the comics, or all the things they like to do, like crocheting and knitting for hours. It's going. You may have to reroute them back and back and back and back because they are having a shorter time of attention. Again, you'll see the mood changes with the depression, the apathy, the aggression. You'll also see the disinhibition that I talked about earlier. You'll see the agitation and the aggression. But the key thing to remember here is memory still may be intact. And when I do my teaching and I go into long-term care, I say, and I've said this here already today, is that just because they remembered that they did it doesn't necessarily mean they can stop themselves in the moment. And I think that's one of my main key points to take away from this today, is that when we're caring for, when we're working for people with dementia, we don't see the impairment. It's in the brain. And dementia is a very, very brain-based behavior. And so when I'm talking with staff, I'll say, so would you ask somebody with knee amputations, leg amputations to run a marathon? Would we? No, we wouldn't. But yet we continue to ask people with dementia to do things that they can't do, even though there's major parts of the brain are missing. And so I really challenge people to go back and really go onto the internet and take a look at brain slides of people with Alzheimer's disease or Lewy body or different types of dementia. Because there are holes, there are places in the brain that aren't working, they aren't going to come back. And so every time we ask them to do something, that part of the brain is gone. We're just setting them up to fail. When really, working with dementia is setting them up to be successful, and how do we do that? So mixed dementia is a combination of any two types of dementia. So what I typically see is Alzheimer's disease and vascular dementia. But again, we've also seen in Saskatoon Health Region long-term care homes, Alzheimer's disease mixed with Lewy body dementia. Again, with mixed dementia, the symptoms may range depending on the area of the brain that are affected. So with Alzheimer's disease and vascular dementia, I typically see people that are asking for rides home in nursing homes. They can't remember where their glasses are. They have the repetitive questioning. They don't realize that they're in long-term care, and they ask 150 times a day, could I go home? When's my wife coming? When am I here? Combined with the vascular dementia of the aggression and the disinhibition and not understanding the consequences. So you do see some aggression. You do see some hitting out. With mixed dementia, the symptoms range, and in many cases, the symptoms may be similar to or even indistinguishable from those of Alzheimer's or another specific type of dementia. Just remember, in most cases, a person's symptoms may suggest that more type of dementia is present. So it's really it's tough sometimes to go, this is Alzheimer's disease and this is the vascular dementia, because the symptoms are very, very close. You will see more people with mixed dementia than you will see with something like Lewy body or something like vascular dementia. So again, if it is with mixed dementia, with the vascular, again, remember that depending on where the strokes are happening, is where the behaviors you're going to see are going to have impairment in. So if the impairment is in the frontal and the temporal lobes, you'll see personality, region, and judgment changes. If you'll see it in the occipital lobes, you may see some eye changes. The cerebellum, you may see some balance changes. So again, it's really tough to say. I never ever say one person has the same type of dementia. If you know one person with dementia, you know one person with dementia. It's very, very different from person to person. And I think that's another key message to take away from me. What I have with family members with dementia would be very, very different than what you will have yourselves. And it's really about knowing that person. And it's knowing that person before the dementia. And as caregivers, I don't know who's all nurses in here and who's special care aides and who are family members. But you'll hear me say it for 10 years. You need to know the people that you're working with because they're the clue to why they're doing the behaviors. I just worked with a gentleman the other day with vascular dementia. And he was having a really hard time getting up in the morning and very, very aggressive during care. Well, he was a World War II survivor. Mornings were not good for him. Staff would come in, flip the lights on, pull the blankets back. They'd scare him each and every morning that he got up and he would hit out at him. Wherein for 5 seconds, maybe if we'd have just turned the light on or just maybe opened up the blind and announced that we're here instead of going guns a-blaring and trying to get our care done. So really, our personal history impacts who we are with the disease. And the more we know about that person, the easier it is for us to be able to care plan and provide a strategy that will work. I can come up with the best solution in the world, but if I have no information about family or from family or about that resident, I don't know. And so a lot of this working with people with dementia is really about the detective work. And it's involving the family, and it's about taking the time for the family to give you the information that we need because they're the caregivers. They're the ones that are going to know. So when you have behavioral and psychological symptoms of dementia, you will see somebody, if someone has been diagnosed with dementia, any type, you will see some type of behavioral at some time in the disease progression. So you will see what's called BPSD, and that's called Behavioral and Psychological Symptoms of Dementia. So these are non-cognitive symptoms associated with dementia. So you will see symptoms in perception, thought, content, mood, or behavior that frequently occurs in residents with dementia. These are also known as neuropsychiatric symptoms, and that's not typically a label that we use very often. I stick to, these are just the behaviors that you're going to see as a result of the dementia. So now that we've talked about the different types of dementia, what am I going to see? Well, there's two kind of camps that you're going to see. You'll see behavioral ones and you'll see psychological ones. And the behavioral ones that you will see are agitation, so banging at the door, pounding at the table. Aggression could be considered hitting out during care, punching out during care, screaming, repetitive calling out, cursing, frequent repetition, asking the same question, when do I get to go home? Restlessness, where you just can't sit. You've put that person to bed 3 times and they're up 8 times at night, wanting to go outside or wanting to know what time it is or wanting a drink of water. You'll see wandering. You'll see hoarding. And again, when I look at hoarding, I have to think about the people that I work with in long-term care. A lot of my people that I work with, the residents that I love dearly working with, have been from rural Saskatchewan. They've grown up through the Depression, and if they have short-term memory loss, they don't know it's 2014. It could be 1928, 1938. What was short in 1938? Sugar, toilet paper, salt and pepper, Kleenex. And those are the things that I typically see people taking. And so are they hoarding? Maybe, but there's always a reason why they're doing the things that they're doing. We just have to sit and think a little bit about it. No one has died from ever hoarding. And so staff say to me, well, Tracy, you have to come out here and help us. She's a hoarder. Just wait till she goes to activity and take the stuff out of her room. Just easy, like why fight? When I'm talking about to staff, we need to pick our battles. What is it worth fighting and what is it not worth fighting for? Urination and defecation is something that you will see, especially as the disease progresses. They're not able to handle their toileting or their bowel movement anymore. And you'll have frequent requests for help. On the psychological side, you'll see personality change. So you may see the resident go from a very mild, meek person to somebody that swears a blue streak. They never did that before. You may see some anxiety where they don't want to be left alone. You'll see some depression, crying, Hallucinations, again, the hallucinations can be sight, taste, and feel, and sound. They'll have delusions, and the delusions are the belief that there's something that really isn't true to us. They'll be apathetic, and so they don't want to be, they can't think to involve themselves in activities that are going on. You may see an elevated mood, so they may be hypermanic. They may be happy and jumping and dancing and hugging and all that kind of stuff. Or they're very, very irritable. But if you notice on that slide, several of those behavioral or psychological symptoms of dementia have asterisks beside them. That means that these particular behaviors do not respond to medications. So screaming, cursing, repetition, hoarding, wandering, there's no medication, there's no magic pill, there's nothing that will help with these except for non-pharmacological interventions. So I would love to say that I have a magic wand whenever I go into a nursing home or into a hospital to fix it. I can't. There are just some behaviors that do not respond well to medications, and by trying to use those medications, you're actually making the side effects of the medications are actually worse than what the actual behavior is. So what is the prevalence of behavioral and psychological symptoms of dementia? So if you look at the slide in your first bullet, although cognitive impairment is the main feature of dementia, non-cognitive symptoms are common and can dominate the picture. So 60% of community-dwelling patients with dementia have something either behavioral or psychological, or 80%, greater than 80% of patients living in nursing homes with dementia will have some type of BPSD. Unfortunately, 90% of people with dementia develop a neuropsychiatric or a behavioral symptom during the course of their disease progression. So somebody will get something at some time. I just want to talk a little bit about the overall prevalence of it. What we're going to see in terms of prevalence of sort of behaviors, 15 to 30% of people in nursing homes will have psychosis. 30 to 50% will have depression, 30% will have physical aggression, and 50% will have physical agitation. So there will be something sometime along the way for that particular person. The goal when you're working with that caregiver, whether it's in long-term care or the hospital or in your home, the goal isn't to cure it, because it's not going to cure. It'll eventually change. The symptom may go away and be replaced with something else. It's about minimizing it, and it's about keeping the quality of life of that person as best we can in that moment. So if you look at this slide, it just shows you with Alzheimer's disease sort of the peak frequency of where symptoms will occur. So suicidal ideation, social withdrawal, depression, paranoia, accusatory behavior, anxiety, those things typically happen about 10 months, between 40 to 10 months before diagnosis. And then 0 to 30 months after diagnosis, you'll see mood changes, irritability, wandering, aggression, agitation, hallucinations, socially unacceptable behavior, and sexually unacceptable behavior. Your symptoms are likely to occur earlier in the illness on the left-hand side, and the agitated and the psychotic behaviors are frequently observed with moderately impaired cognitive function, but normally declines in advanced stages of dementia. So there's a huge difference between the symptoms that happen before diagnosis and the symptoms that happens after diagnosis. And it's not the fact that you've been diagnosed, it's just the time frame of when they happen throughout the disease. So when you look at the BPSD, or the behavioral and psychological symptoms of dementia, there's a lot of things that can cause behaviors. And these are just some of the things that I've noticed I call them the triggers. These are some of the things that actually can cause the behaviors. And they're things that sometimes we don't think of as a trigger, but they truly are for that person. When you've been diagnosed with dementia, you lose so much in your life. And you're grieving and you're losing things. And so some of these things actually may not for us seem to be a big deal, but for that particular individual with dementia are. So some of the common triggers are sensory loss. So when I go into nursing homes, lots of times I'll see my residents don't have hearing aids or their glasses. And they haven't had their eyes checked in 10 years, so I can't imagine what they're seeing out there. And that's a trigger. Are they fearful because they don't know what's coming towards them? Physical decline is an issue. Loss of control. I think this is a big one. When you come into long-term care, you're kind of on the routine of the staff. So most homes are very, very good with when you're getting up, but you know, you're being told when it's time to eat, and you're being told when it's time to go lie down, and you're being told when you're getting your medications, and you're being told what you're going to wear that day. I don't like being told what to do. So I can imagine for me that will be a trigger. I need to have some autonomy, and I need to have some independence in my day. Care-related staff issues. If you have short-term memory loss and you have caregivers that are coming in to give you care, you don't know them from Adam from day to day to day, even though that the staff know you've been working with them for years. Imagine what it's like if you woke up in a strange country and two people were trying to take your pants down. You'd fight because you don't know what's going on, because your memory is so short. Those people could have left the room and your memory is so short you don't know who they are when they come back in the room. So even care can be an issue. Pain. This is where my brain goes probably 95% of the time when I see behaviors, especially the hitting out during care, is pain. There are so many elderly people that are unmanaged with pain, and I don't know, and that's another topic all unto itself, that they're not adequately managed for pain. And so they're being transferred, they're being moved, they're seated in their wheelchair for hours out of the day. I'd hit out too if I hurt, if somebody was trying to move me around. So always look at pain just to make sure that that's managed. Boredom. Sleep deprivation, medications. There are certain medications that cause the need to get up and go, cause them to be anxious, so it's always helpful to do a medication review. Overstimulated or understimulated. Again, I go to nursing homes, and so a lot of them are loud, the lights are bright, there's lots of people around, there's lots of noises. That in of itself can cause an issue. For me, myself, I'm very extroverted, so that's probably not going to be an issue for me. But for my husband, I don't imagine an overstimulating environment will be helpful for him. And again, always look for thirst, hunger, and toileting. Because sometimes people aren't able to say what they need to say, and so sometimes those behaviors are just as a result of an unmet need physically that we need to figure out. So just a quick algorithm when you're managing the BPSD. A couple of things to look at. You need to identify and target. So the first thing is to target, tell me when they're happening, try and figure it out. Make sure there's nothing new medically going on with that person. Go to non-pharmacological interventions to manage. If that doesn't work, you go to using pharmacological treatment. You start low and you go slow and you review with your medical team if indeed a medication is required. So my key principles are treat pain, make sure that person is engaged, allow them to do things that match their ability. And when you're doing activities, remember the activities are stage appropriate, not age appropriate. Ensure levels of stimulation aren't too low or too high, and make sure that the family members are always involved in care planning, because they're the keys. They know their parents the best. They can help us plan. Our staff in long-term care are trained in managing responsive behaviors. Other things to do is validation therapy, use exercise, use music, and use sensory stimulation. A really good music is a thing on Netflix is called Alive Inside. If you want to see the power of music on somebody with dementia, go watch that. It's an hour-and-a-half documentary on how music impacts people with dementia. And that is my talk on dementia for the time being.